Welcome to another episode of Living with FASD, Candid Conversations with Patti Kasper. This podcast is for those who are living with the effects of prenatal exposure to alcohol, their loved ones, and anyone else wanting to learn more about fetal alcohol spectrum disorders. Each week, you'll hear from someone whose expertise is either professional or living experience with FASD. I'm your host, Patti Kasper, bringing you both. Now let's get started with another candid conversation. Welcome to another episode of Living with FASD, Candid Conversations with Patti Kasper. And I am absolutely delighted this week to bring you a guest, a very special guest who was highly recommended by Jody Culp, who you all know is one of my favorite peeps. So Dr. Janet Oliver has her doctorate degree in developmental psychology, and she really looks at the very most basic, primitive, important stuff going on in our brains, how that spills out into all of life. So without further ado, Janet, thank you so much for sharing your time with us on Living with FASD.
Well, thanks for inviting me, and I'm always happy to share this very important field that really is growing, but is still in its infancy in a lot of ways.
Yeah. So I know you've known Jody for a long time, and you've known her daughter, Liz. And the things that you were able to teach Jody really were foundational in the progress that she was able to make with Liz throughout Liz's short life. I say short because, 30 something years is pretty short.
Mm.
So Jody's known of the importance of primitive reflexes and in our development, in our skill levels, in our abilities to scaffold up, right? But this was brand new information to me. And the episode that I had done with Antonia and Jody, wherein we discussed this stuff, I think I'm going to, put a link for the audience to circle back to that. It was such a good introduction. And so I'm so excited you're here to do the deep dive with us about why it's so critical and on. So I know you listened to the episode with Jody and Antonia because I sent it to you. I'm curious what your thoughts were and if there was anything that you want to dovetail into with that prior conversation.
Yeah, hi. Yeah, I did listen to it, and what I found was what was so important is the principles of the approach. In other words, the way that they the respect for the person and the gentleness and the watching and the individualization of each person. That is huge for us and me. And because although you can group things, and we always do, as you know, people are so different in any spectrum of developmental difference. You're going to see huge differences, and that's where the individuality comes in and the concern and respect for every individual. So that was really highlighted. I don't always hear that with people, so I was very, very happy to hear that. And also the kind of weaving in and out of the sensory and the motor concerns. It's very important to me, to everyone, to understand that reflexes are not just a separate thing. They are things that are normally in typical development are triggered by in utero, most of the primitive reflexes, and there are other reflexes as well, but as they're triggered by a sensory effect of some sort. So it's usually something to change in gravity, change in position, or change or tactile touch in the beginning. Those are the main things.
So would that be perhaps what is in the works when mom changes position and the baby starts kicking?
Yes. Would be happening. And when a baby is born, traditionally we think of, they used to hang the baby upside down. Not necessary, but they would
and spank the butt.
Yeah, well, they wanted the big gravitational change. they wanted the strong tactile input, right? And that's because that can kind of wake up. Now, reflexes are we develop them in utero, and depending on the in utero environment, they're going to change. They're going to have reactions in utero to any kind of toxicity, any kind of positional problems, any kind of womb issue. And we could talk about that because that also comes in here. Again, this is just where people are, and the body's reacting to that very early. And sometimes even emotional states. It's not as common, but trauma or emotional state of the mother can occasionally cause, it's not as common as people think it is. Often people go there first. It's not the first level, but it can be one of the factors. Okay. So when a baby is born, I call it you're going into a whole new world. So you're going out of a womb where you're floating, and the gravity is your buoyancy, and it's dark and it's soft and it's wet and it's it's all muffled.
Cozy warm waterbed.
Cozy, right? And so when you are born, though, that's the vaginal birth, although there are less and less of them, we are getting to the point where we're a very high percentage of C-sections. So they're trying to draw that back a little bit, but it's still very high, and sometimes it's necessary. I don't blame anybody. You are where you are, and you do what you have to do. But I do think thoughtfulness on that is a good idea, because vaginal births are important when they can happen safely to transition the motor patterns. Almost all the primitive reflexes help and assist in birth. Okay. So they have a place in birth, and they have a place after birth. I mean, it's amazing the developmental patterns that go into that. So at birth, and a lot of times with some of these patterns, things go wrong. Tangling up of the cord is very common, these kind of things. So it's not always possible, and you can always make up for that problem if you know how to do that. So if you've had a C-section or a baby hasn't gone through it, a good pediatrician or a neurodevelopmental specialist will be able to tell you, how can we make sure that development of that motor programming.
So what is it about the process of birth that is so helpful? Is it the experience of deep pressure?
That's one of them, but the baby helps itself be born. I mean, we think about the mother doing the labor, but the truth is, the baby does labor too, and that means with the spinal glut, you have the back and forth movement, and with the Perez, you have the up and down movement, and with the ATNR, you're getting the head ready to be presented. So there are a lot of things going on in the body that obviously are happening automatically because of the pressure, because of the triggering of the tactile and gravitational change. Okay, that's happening during birth. So those things help the baby be born. And after birth, then the first 3 to 4 months are extremely important in reflex development. They're one of the really important, and we're not even thinking about that usually. We're just thinking about trying to get through it usually as a
right?
So, but people go, I never noticed that. Well, you probably wouldn't have noticed a problem. And sometimes pediatricians check reflexes, but when they check them, they check very few of them, and the ones they do check is to make sure what they're looking for is extreme neurological damage.
Okay.
They're not looking for subtle.
So give us one or two quick examples of the extreme neurological damage that the typical obstetrician would pick up on.
Okay, so they're going to do, people do different sets of them, but the ones that are common are the pull to sit, where you hold the baby's hands and you try to pull the baby up a little bit, and the baby should clamp the elbows closer and stiffen the core and even the head and the neck. They're looking for that. If the baby's flaccid and doesn't do any of that, well, we should probably get that checked out, so they will see that if that's an extreme thing. But even then, they don't always do anything about it, to be honest. I don't know if they know what to do. See, that's part of the problem. That's not their department. So that's the problem with that. The other one is something occasionally they'll do rooting. And rooting is where you touch the cheek and the mouth.
And they turn toward it. Yeah.
Right. And so that's another one. And occasionally they'll do the ATNR, but the asymmetrical tonic neck reflex, which is a very important neck reflex. But they'll, like, my grandson was born premature, had a vaginal birth, but was very young. And I knew we would be having some things I had to look at. And the doctor did notice, he tips his head more to the right than he does to the left. He did notice that, but all he said was just keep rearranging it. Well, we had to do a lot more than that, but he's fine now. So these things with torticollis, things like that really can affect the development of these very, very important developmental patterns. And if the motor patterns, say my grandson only was turning to one side all the time, well, that changes the neck, it changes what you're hearing, it changes how your eyes work, changes everything in later development. So that is important to be able to notice right off the bat.
See, and I was just hearing that thinking, predominantly right hand versus left.
Yeah, that doesn't really have to do with dominance. It doesn't really deal with dominance.
Because if you think about it, most people end up, if they have to stand for a long time, generally weight bearing on one side versus the other.
Yep. Everyone has a little bit of asymmetry in their body, and you have a dominant side, but this sometimes is against the dominant side.
Okay.
And there's many patterns. ATNR is what I did my doctoral thesis on it. It's a very deep subject and has lots and lots of different parts to it. But just noticing that the head turns easier one way than the other can be really important in this early part of development. So then at about 4 or 5 months, and again, these numbers, there's no typical thing except this is the typical kind of general pattern. The baby starts volitional movement becomes more important, and it's been informed by these early reflexes. But the reflexes, now again, this is the theory, and this changes a lot too. There's a couple theories, and I think they're both not incorrect. One is that the lower brain holds these patterns, these automatic patterns, which everyone's born with. Everyone has them.
Lower brain being the parts that respond to fear, trauma, that
well, even deeper than that. We're talking about brainstem. We're talking about really low.
So the autonomic system, breathing, heartbeat, rhythm.
Right. So we're talking about really low area. And yes, they do wire up to that fear and other area early on. So that is happening. That happens at about 4 to 6 months. They start wiring up to the fear and alarm system. So that does happen, but it happens a little later. The first things are these, just these motor patterns. That's all they are. And they're helped to sort out in the cognitive motor cortex. What's sidedness? What's up and down? What's this thing here? What is that? What does it do? And so we spend a lot of time doing that. But this is, I love watching babies. I watch babies all the time, not because you have to only work with babies. The nice thing about reflexes is you can work with them anytime throughout life and catch up with things that didn't happen when you were young. And that's what's so hopeful and encouraging about them. So as you get a little older, then, you're starting to put patterns together. Your reflex patterns get inhibited in the lower brain, but integration is when you can use those patterns freely. In other words, and give me an example, because sometimes it's hard to understand. This is an easy one. I do this.
I love examples.
Okay. So with the Babkin reflex, when you press the baby's hand here or open the hand, the mouth opens. Okay. So what we sometimes do with people is we go, okay, open your mouth and open your hands really, really wide. And now close them and close your mouth. Now open. Now do the opposite.
That looks awkward.
It's hard. It's very difficult. Most people have to go, wait, what? But when you practice it, that's kind of that integration. You're using the pattern, breaking the pattern. Yoga does this a lot. Yoga uses a lot of children patterns, but then they break them. right? And that's an integration activity to integrate those reflexes. So you're using them for what you want to and how you want to, because they're very strong patterns. They never go away completely. They're just inhibited by the upper cortex motor patterns. So that's how it works. And oh, the other part of this is weight. it's your gravities. Your gravity. When you're an infant, you don't always have the gravity to center you and to put you in control of your body. And so you'll notice when babies start being able to weigh a certain amount, sit up, and then start to crawl and these kinds of things, they've gained quite a bit of weight in that period of time. And kids who don't, it takes a lot longer for them to do that.
So your failure to thrive babies are going to be delayed in the development of some of their reflexes.
Yep.
And failure to thrive is one of the hallmark symptoms of FASD.
Correct. And that we see that. And that is, so therefore you're already kind of behind the 8 ball, as we see with a lot of different, again, this is not just, the fetal alcohol syndrome or effect, but it's also in a lot of different things. You get splintered development, what I call. So some things are running really well and they're working, and other things are just completely shut down and not working. And that was something that you talked about in your other podcasts, and I think we see that a lot. So trying to figure out where that is, and we don't run through every reflex for every single person. We try to find what is the thing that's missing, and Jody talked about that in that podcast as well. So and one of the things you talked about was the fear paralysis effect. It is not a reflex, you're right, it's a response. It's before you really have reflexes going. In utero, in the embryonic period, the spinal cord, everything's not set up for actual motor reflexes, which are stereotypical patterns when you have a sensory effect. So that these are the things so in the fear paralysis, it's very early. And what happens often with that, and we talked a little bit about it, is a baby in utero, if they are getting some substance that's toxic, and that doesn't have to be just alcohol, it can be a lot of things.
I think it was Dr. Ira Chasnoff said there's over 10,000 neurotoxins.
Right. Yeah. Some of them don't go through the blood-brain barrier. Some of them are protective, but not all of them. And the ones that don't, we got this umbilical cord, and what can actually happen in that embryonic period, and you're very tiny, you don't even have, just getting organized. And this is fear paralysis often, I'm not sure, I can't say always because we don't have enough research on it, but often happens during the time the eyes are developing.
Okay.
And what happens with it is whatever that is, and sometimes it's toxin, and sometimes it's being implanted too deeply in the placenta, and it is not enough. It's keeping nutrients and things from actually coming in at all, or very little.
What is being planted too deeply?
When the egg comes down,
okay,
the placenta. So the placenta, depending on many things, is almost infinitable.
Gotcha. So where in the womb it implants?
Yeah, implant where or how deep. Believe it or not, it plants like a little seed almost, and that depth of that can sometimes close off that umbilical cord development and tighten that. Okay, so we see that, and the little bit of research we've done on it, it does seem to be something that if someone has a placenta difference of some sort, it's more likely. It's not 100%, but it's more likely. So both those things, what happens is the embryo is in kind of shock. Okay. And that shock, what happens to a cell when it's in shock? When a cell gets into shock, it does what every creature does as well, which is go in, contract. Okay. And this is a contraction action. Okay. In the eyes quite a bit of the time, because that's what's being developed right then. So there's a contraction. Okay. And that may or may not come out in different degrees of this, right?
Is that why people close their eyes when they're frightened?
Often, I think there is a relationship to that. And not only that, but you can kind of see a severe fear paralysis in people through their eyes. As a matter of fact, even as adults, you can see that kind of, no matter, even if they're happy, their eyes look sad or extremely fearful. And they may say, I'm not afraid, but their eyes look really like they are, like if you read their eyes. And we have some pictures of those in classes that I give to show people that. But I sometimes sit at the airport and go, oh, there's one. Oh, that one over there. Because you can really see it in people's faces, how they look. So knowing that, we came up with a bunch of different ways to deal with this. And one of the ways, we just found this out just not even that long ago, maybe 5, 6, 7 years ago, that the lymph system is actually attached to a lot of the cranial nerves that are dealing with these different, like the eyes, okay, and the vagus nerve. And these are like nurses, I call it, to those nerves. And those are cranial nerves, and cranial nerves are major nerves of sensory motor activity. So what happens is we've done a lot of different, and people have come up with all kinds of things to deal with the sensory motor, and they all work different with different people. So I'm not going to say that's the only way, but practically speaking, facial and body lymph massages, which are very light, easy, quick massage over your body, you can find them all over the internet, actually can help with this fear paralysis effect. It's one of the things we see that can kind of change, lower that, because how we see this is, and she, I don't know who said it in the podcast, but they were saying that it's attached to the fight, flight, and freeze, which is true. But as you can see, the embryo is a long way from having any kind of emotional attachment at that time. What happens with that is it becomes that. It grows into that. And a lot of reflexes are like that. They go from here to here to here to here. They're the
purpose for them adapts.
Right. And they come along, right? So fear paralysis, if you have it, you will often be like more, if someone comes up to you, you'll have a tendency to kind of freeze inside. And people who have it, I'll just explain it. I'm going to walk towards you. Okay. Tell me when to stop. And they said, stop already. Don't even come to me. They know that they feel that grabbing in themselves when someone's coming at them. Or sometimes it's them coming at someone else. It can be both sides of that, either coming or going. Now that, like you said, then you're in a certain state. And now how do you react to that state? You have those 3 choices: fight, flight, or freeze. Okay. So it's a freeze at first. And then what am I going to do with this? I feel trapped. This is not an upper brain thinking thing. This is a very low brainstem effect. So it isn't someone going, oh, I can just stop doing this. I can stop running away, or I can stop hide my face. As a matter of fact, some people have elective mutism who have this as well. It's another thing we see. It's not everybody who has it, but they will only talk with people they're comfortable with perfectly well. But when they're in an unknown situation, everything shuts down because it's all in contraction. See? And so learning how to deal with this and be able to move past that.
When you said that, I'm thinking of an individual who is actually quite shy until you get to know them, and it turns out, amazingly, they're the class clown.
Yeah, some people use different ways of dealing with it. Like we know that a lot of comedians have kind of their own neurodevelopmental issues, and it's not an accident. That's a part of that. And again, we don't want to take away the gifts on these, because some of them have gifts to them. I mean, it really can be a really mixed bag with things, but you want to, I always say, I want the person to make the choices, not the lower brain alone, because the lower brain runs your automatic system. And if it isn't happy, nothing's happy. And
nothing works right.
So that's why we work there first, because of that. And in saying that, the reflexes and the sensory development go together through this early age. So it isn't just a motor pattern, it's a motor pattern that trains the senses to a higher level. That's what they all do. Okay, so they're learning how to go from moving without startle in gravity.
Mm-hmm.
The first thing, like a lot of people startle through. I mean, I was one of those because I had a very terrible birth myself. I was breech born in the days before C-section. So they had to turn me around and pull me out with forceps. I know exactly where the forceps were to this day. I know exactly where they were. Okay.
Wow.
As a matter of fact, this sinus is 1/3 the size of this sinus in me.
Oh my goodness, because it got squished.
Yep. And even with all the work I've done, it's can't open it up. But it's I've been able to get along with that. But that birth gave me a lot of understanding of how this affects. I think you were talking about the moral reflex in that podcast. The moral reflex is a gravity activated reflex for breathing and for being in when you're first born, right? But it then is supposed to transition into a nice healthy startle reflex. Everyone has startle reflex, but you're not supposed to do like I did, which is when someone touched me on the shoulder, startle and feel the leftover tremor of that for 20 minutes. Like, okay, that's too much startle reaction.
You also don't want to just hit them.
Right. Well, that's what I did. I had to tell my students, because I was teaching at the time, not to touch me on the shoulder from behind, because I would do that. Right. And I wasn't trying to hit anybody. That was an automatic motor response coming from a babyhood where I had never had my moral reflex taken care of. And having said that, that affected my body space and somewhat my gravity sense.
Yeah. And I think too, I mean, that shows up in later life as well. I mean, I'm thinking typical PTSD kinds of hyper responses that maybe were tailing on earlier issues. Yes. Because my husband was in the service, bless his heart. And so I had to adapt the way I would wake him up.
Yep.
Compared to how I would wake someone else up, just out of self-protection. Because there's when you're in that sleep state, you're not thinking,
right,
oh, this is someone I trust.
Reflective reaction. And so if these reflexes were never really well integrated to start with, or never really even inhibited, or never even really working at all, which sometimes happens, you're going to see some of these later things are going to start piling up. It doesn't mean the person's not smart, doesn't mean the person is capable of doing many things, but our cortex, we get cortex driven. Our cortex is going to go, be quiet down there. I'm going to do this, right? I don't care. I got to do this thing. Get out of my way. But the problem is the bottom brain is not going to be satisfied with that forever. And then you end up with panic attacks and reactions to environment like over control, or other issues that come out of a fear. It's a fear, and it's not a fear that's cognitive usually. I mean, although cognitive fear can trigger it, it's also usually it's because we can't regulate those visceral feelings that brings into us. So in my book Inner Senses, I work with we talk a lot about all the way through life. It's done from the beginning of life till older age on how to look at a system that with a gravity sense, which is how you deal with gravity, which is how your motor slack your muscles are in rest, and not how strong you are, but how you can, like, how long can you sustain your eye focus, or how long can you keep up a motor pattern. All these things are going to be part of your motor system. And of course, gravity sense has a lot to do with your balance, your inner ear, and how you work with the world, right?
So I had a question, and I hate to interrupt, but it just kind of circle back to something that went, like, I don't know, 15, 20 minutes ago. My mother has Lewy body dementia, which I believe is very connected to FASD, because there's just way too many things in common for it to like the lay of the land survey that the adult leadership collaboration of the change makers, FASD change makers, did this survey years ago where they found 428 comorbid conditions, right? Physical conditions
Yep.
that those of us with FASD have a statistically significant higher risk of developing. And so they noticed with dementia, that was a huge one, 206 times more likely to
Wow.
have early diagnosis. But it was lumping all dementias in together.
Mm-hmm.
But there's hundreds. If you listen to Teepa Snow, who's an incredible PT, OT woman, very gifted teacher, but I mean, there's just so many forms of dementia. Anyway, that's like rabbit trail. One of the symptoms that she complains of the most is how heavy she feels.
Oh,
As
interesting.
if the gravitational pull for her is really ramped up and multiplied compared to what she felt earlier in life or what the rest of us would feel. Does that have anything to do with some of these reflexes that you've been talking about?
Yes. When we're we do all kinds of checks on the gravity sense in many, many ways. But what we're trying to figure out is, again, some reflexes, again, you will see the gravity reflexes in there. There are a series of them in development that some people have what we call a hypo sense of gravity. In other words, they're not feeling it enough. And when you don't feel gravity enough, you're all the ones who are like going to float up off the ground. And there's people there around. And then you have the other side, the hyper sense of gravity, which will make you feel like you're weighing a lot and you're can't get through the
Yeah,
gravity.
it's like she's full of lead
Yeah.
instead of full of blood. And I know that's one of the Parkinsonisms, right? So that's a common symptom with Parkinson's disease.
Mm-hmm.
So is
Brain
there
issues, that have to do with the cerebellum and the brainstem. And yes, you'll see that kind of thing in there. Now, I don't know where the limit is. I always think I have a limit on how these things can help restore, but I have found that things I thought couldn't be restored can at least be improved.
okay?
And because those reflexes don't go anywhere.
Yeah.
They're there. Okay.
Yeah.
And so we see them as therapeutic, not just as a developmental thing. You had trouble with them when you were young. If you get older and something happens and you're starting to lose some of the things, like one of the things they look for in dementia is whether your rooting reflexes come back or not.
Mm-hmm.
That's one of the main tests. They go, oh, look, it's coming out of inhibition, which means the brainstem is no longer cooperating with the cortex as much, right? So now we have some kind of disassociation with that. So that is what they're looking for. So being able to work on just, I even say what I call going through the forms of the reflexes can sometimes be enough for people to keep improve and then just at least keep a moderate amount and not keep going down in some of these areas. Okay. So it is something. Some of these are very they develop and then they just kind of stay at a level, and some of them get worse and worse and they're debilitating. But trying to keep these things in, and I think with the alcohol syndromes, they also have this where's the things that are happening in the brainstem and how much can be regained and how much can be sustained at a level that's better than having things be lost. So that is kind of how we look at it. And so in the book Inner Senses, we look at those developmental stages, but you don't have to be that developmental stage to do those things that are listed there. You're looking at, that's where my problem started, like in utero, or maybe because for me it did. My stuff started in utero. Okay. So I needed to start all the way back at the beginning. But some people, it's later in life and something came up, or there's an accident or something happened where,
TBI or a stroke.
exactly, those
Yeah.
things. And that then you can use these patterns to at least, we've seen with strokes, and even with, I did an early study with different TBI injuries. And boy, it was a mixed bag. We have everything from a gunshot wound to, to an aneurysm, to, it was a bunch of different things in the population. It wasn't one population TBI, even though they're all TBI. But we saw improvement with all of them to some degree, even though some were 10 years post. So this stuff doesn't go away.
And I think too, that's one of the really interesting bugaboos about FASD, because it is both a traumatic brain injury from the alcohol killing many of the brain cells outright and just changing the structure and therefore the function of others. But it's also an acquired brain injury,
Yeah,
because it's passive, it's both active and passively received. And so therefore, because you can point to the other, it typically is left off both lists.
yep. I agree with you completely on that. I think that's really, really true. And I think that's why, when you can figure out that, I started this when I was an educator, and I was asking myself, why are some kids really not able to like read when they're right, and other ones totally get it. So what I found out from a lot of people, including Dr. Lyle Palmer, who was a neurodevelopmental specialist from Winona State in Minnesota, he helped with the Chance to Grow program here, and he was my first teacher, and he's still around. He's a great guy, and he was talking about how so many kids can't even cross the midline with their eyes in the movement, right? And that's a control, that's a really fine tuning thing that has to do with your gravity sense, which gravity, you're supposed to be able to hold your eyes still when your head's moving around. Otherwise you get seasick and you get, feeling like you're gonna, stomach problems and stuff.
That's vestibular sense, right?
Right. And
which is why I can read if I'm in the front seat of the car.
right.
I can be a passenger in the front seat of the car. Don't ask me to ride in the back.
Yep. And that's because you're giving your eyes and your vestibular system two different messages. And the brain hates that.
Yeah.
It will do everything to try to right.
And being able to root your vision at the horizon is probably the best thing to calm that down once you get triggered that way.
And stabilizing your eyes, and yes, at the horizon's ideal, but even being able, but when you're in a car and you can't do that, your bottom brain, all it knows is there must be a terrible disaster happening, and we have to, and what happens with the vagus nerve, it wants to chuck anything you ate. It wants to get everything, so you have as much energy as you can to get through this incredible emergency that you are in the middle of, right? And of course, in reality, you're in the backseat of the car. But it doesn't work.
Yeah, and if you're looking out that side window, everything is rushing across the midline speed.
Yeah. And it's going more into one side of your peripheral vision. And the peripheral vision, I do a lot of work with this because older people get this a lot, that goes straight back, as you know, probably this, the middle part crosses over in your eye vision, and this part goes straight back. But this side is for quick processing for emergency, because something coming at you from the side. And so your amygdala and all your midbrain area is going to be going, what is that? And so that also can be triggered more when you're in the back seat and you have this, it is an awareness, an overprotective lower brain, because it's constantly being activated by some of these problems that come through the developmental issues that we're talking about.
Yeah. I was thinking also, and this is probably totally separate, when we went on a cruise, we armed ourselves with seasick pills and whatnot. But we found that the cruise ship is so big
But,
that we didn't have an issue. And then, of course, driving to and from the port, I still didn't have movement issues because I'm still in a car, still moving, still challenging the system. I got seasick when I got home.
yeah. Yeah, that's again, your system can get used to a certain thing, but it's the quick changes that can, especially if sensitized system that's used to going into emergency rather quickly. And that's what would happen when the brainstem has had any kind of trauma. And to be honest, brainstem traumas can happen from almost anything. Any TBI has that. And certainly, like you said, the ongoing trauma of living with these issues and not being able to do what the expectations are around you.
And certainly those of us living with FASD, we have so many things that are putting us, I don't want to say in a deficit, right? But kind of setting us up for these kinds of challenges because we have the initial assault of the alcohol. We have the brain being mandated to rearrange itself in the way that it functions because of the physical damage caused to various and sundry points, depending on what's being developed at the time of exposure. And then we may have a lot of other reflex development issues going on, like, when Jody and Antonia talked about the Moro reflex or talked about that, or the rooting, right? And the challenges with suckling and eating and failure to thrive and all of these challenges going together. And then being in an environment perhaps where there are a lot of adverse childhood experiences.
Right.
Maybe there's ongoing substance use or that, beyond the alcohol. Maybe there's an environment where there's a lot of high crime and a lot of chronic cortisol exposure through the placenta. That damages, from what I understand, the thermostat in terms of, how we activate our excitatory hormones versus our calming down hormones, right? The sympathetic versus parasympathetic nervous systems. But all of this together, and then you add in all the social traumas of being misunderstood and blamed, shamed, and punished for not meeting other people's expectations.
Well, that expectational piece I find is, not a mild or little thing. I mean, sometimes environmental things would be larger, but they're not.
It's huge, especially if you're in a family that's been pulled into the foster care system or the adoption system, because then you have all those traumas on top of all of it. So it seems as though, perhaps you can expand on this, that we may have had those initial traumas prenatally, and we did have these initial traumas prenatally, but they keep getting piled on.
Yeah.
By life.
Yeah, that's right. And they do add up in different ways for different people, and they mean different things, right? And that would be absolutely correct, because once you get something that's already not regulating well, let's just call it that, everything that's added on is one more weight on that system. It's already not working well, so it only has a few choices, and that's to shut down, to over control and try to fight your way through something, or kind of control everything so that nothing you don't have to worry about. You think you don't have to worry about it, but the fear element, and really fear is not, like I said, it's not that somebody isn't safe, they do not feel safe. Okay. And that feeling safe, regardless of your situation, most people don't. Anxiety, generalized anxiety as a whole, I have found, starts at the body space level, and those reflexes that develop that. That's almost, I find it over and over and over and over again.
So what I'm hearing you say in that is we can address generalized anxiety oftentimes through like these occupational therapy approaches, physical therapy approaches, rather than pharmacology.
Right. And I hope with it, and again, just go a little bit into that. PTs and OTs are great, and they're getting smarter and smarter, and they're doing better and better with this area. However, these areas are pretty, they kind of add them on, they're an add-on to those, but really it should be the foundation. I mean, I always say that they really should be the beginning of the trainings and the understanding and how they see their work, because both those works are so wonderful and honorable, and they do such hard work and good work. You want, but I find when I work with a OT who doesn't have any training in reflexes or in sensory motor, or a PT, when we start working, their work just skyrockets. It goes much better. Why? Because those really bottom level things, and going with the principles, we'll go back to the beginning where we started, that systems are sensitive. They've been through a lot. You need to just start a little bit and listen. If that bottom brain that's scared says no, I go, okay. You're not forcing people to do things. My program never forces anybody to do anything. Okay. And they said, well, how do you get anything done? Well, you start with what can be done. Okay. And sometimes that's rocking, the rhythmic therapy, or maybe it's something that is even less than that. Maybe it's just the cup holds, where you can calm the system down. Maybe it's the ISP that is like audio help for the vagus nerve. Maybe it's some other things. So there are lots of ways to start incredibly gently. Like we start with, okay, ocular vestibular, but think about where that is in development. Child's not doing ocular vestibular work until they are six months, 7 months, 8 months, and even older. So that work is pretty high on that chart.
So let's spell that out for the audience. Ocular vestibular, so that's the communication between the vision and the sense of where you are in space.
Right. Well, when I move my head, my eyes have to keep stable to some degree.
Yeah, because they don't do that.
Right.
They do this even though I'm still like maintaining eye contact.
Right. Your eye needs to hold a focus even when you're moving your head. You can do that. Okay. And that's the ocular vestibular. And that doesn't develop. You watch a baby, they can't do that. That is, and because that takes a certain developmental time. Now, the reflexes do help with that. And that's part of their job, especially the neck reflexes, the tonic neck reflexes. They all are working on that, right? So this is, but they like with my grandson, who I had, he was premature, he had to work through a lot of stuff, and he was coming out of, some trauma, to be honest. And so holding him and doing a slow pull up with his eyes on me, and sometimes I had to help him with his head, etc., and then putting back down. And we started with like just a little bit of tip and back, but now, he's like 7 months old. We're doing like 4 or 5 of those, and no problem, right? So slowly you can get this ocular control if you give it gently. But we look for trauma signs. We look for stress signs when we're working with anybody. And I have seen it, and they're different with everybody. But, it's usually the flushing of the face, or the eyes can't hold it, A lot of times people do activities, they'll go, well, you did it once, so we can get back to that. No, if they've lost that ability, they need a rest. They need time. And I know it seems like that can't be possible. They only did one. Yes, it's possible. People's systems are that delicate, and that triggering of that, once you've triggered that bottom brain, that cerebellum, and that lower brain stem area to go into that state, you're not going to get much.
Does vertigo figure into this?
Yes, vertigo has a lot to do with it. Vertigo is a symptom, so there are many causes for it. But we usually, if it is,
translate to the audience. Vertigo is extreme dizziness.
Yes, and sometimes people get it from like old age. You get it for thickening of your liquid in your inner ear. So that we work with that sometimes. Also, it can be for people who have allergies. The allergens cause a thickening of that liquid. And you have these little crystals in there that hit hair cells that tell you which way you're moving. But if it doesn't get that information, the eyes are going, where is it? I don't know where I am. I don't know how this is working. How are you moving? I can't tell. So these are what we would work on. But it can also just be as simple as it's never been developed into a nice, steady, strong state. Okay. And because of that, you have to start very gently, and we start very, very, very easily. Why? Because you don't want to traumatize the system again. You want to go, okay, you're done. That's fine. You did a great job. Tomorrow we'll try again. And this time, maybe we'll do a little more. Maybe we won't. We'll see. And then we don't push the system, but you encourage the system. And once you encourage it, it's called gentle encouragement. It's what I call it. You will get a lot. People go, that takes so long. It takes
so someone who has challenges in this area, you would not be encouraging them to ride the spinny rides at the amusement park.
Exactly. Or I wouldn't even suggest that they take like a book like mine that has some of these activities at the higher level. Do them. Oh, I had one little boy. This is a good example. I had one little boy who I showed him one of these activities, and I said, you're to do it 3 times, no more. Okay. And I just wanted to do it 3 times because that's where his level was when I started seeing changes in his face, his eyes, his breathing. It was all changing. So I stopped. And the next time they came back, I said, so how are you doing? He goes, oh, I did that one 150 times or something like that. It was an exaggeration, but he was like, I did it a lot. His mother said, yeah. And then he couldn't do any of it for a full week. We had to see it all. So you can do it. You can push yourself through anything, but doesn't mean you're going to have an agreement with your bottom brain.
Yeah. Well, we are through an hour, just about. So I would love to invite you back, Janet.
Sure.
Because we could talk for an hour on any of the gazillion things that we covered already in this hour. So yeah, you are a treasure, and I am already in the process of ordering your book.
Thank you. It's on Amazon if anyone wants it. Yeah, it isn't meant to be the end all be all, but it is a good start in trying to help people in a practical way. And that's what we're doing.
And that really is so important because I have found throughout my career that there have been, and the schools are better now than they were when I graduated, right? Because I graduated like 40 years ago. We know more now, but key issues like adoption, like trauma-informed care, like FASD, they're not covered in the typical grad school program. They're things that we have to be exposed to and gain an interest in it and then seek out further knowledge. So anytime there's a good resource, I'm definitely going to celebrate that and encourage people to not only pick up a copy, but also consider, is there a professional in my life that I'm working with? Or, are my options limited because of insurance, blah, 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 who needs this information also, so that we can work more cooperatively, kind of augmenting one another on, as opposed to not following the prescription.
Yep.
Right. Yep. Which happens so often with families affected by FASD. Oh, you can't do that. The sticker chart isn't working. It's your fault as the parent. Right. Yeah, no. So I'm all about sharing resources and knowledge, and that's the purpose of this whole show. So
thank you so much for doing the work you do. I think it's so valuable, and you're right that there are so many neurodevelopmental little areas that are not looked at. We're not in a factory made of everybody. That's the thing. It's a very unique, very individualistic. It needs to be seen like that, with compassion and with respect, to be honest.
Yeah. And that's why we're trying to steer the bus away from neurodivergent and toward neurodiversity.
Yeah.
Because we all are each unique.
And they bring, like I said, and a lot of neurodiversity brings gifts. I mean, it brings something that we didn't have before. So
Yeah.
to me, I have to, we always look at that. Where are the gifts? Because encouraging the gifts is really important.
Yeah. So much of the early research was all about the deviations from the norm and wasn't looking at people's strengths and gifts and talents at all.
That's right.
Like
That's
that hashtag 34, right? The life expectancy of someone with FASD. Well, yeah, the subjects in that one study were people that had not been identified early, provided supported early, and it didn't look at their strengths,
Yeah.
and that's an important context that is lacking in so much of the research that's out there for people to be able to look at.
Oh, yeah. No.
Janet, thank you again for joining me on Living with FASD, and I can't wait to have you back on so we can pick this conversation up again.
I love doing it. So
All
anytime.
right.
Okay. Thanks.
Thanks so much. Thank you for joining me for this episode of Living with FASD Candid Conversations with Patti Kasper. Feel free to send comments, questions, and topics you'd like to learn more about, hear more about, to me at livingwithfasdpodcast@gmail.com. Please remember to like, follow, and share this podcast on whatever platform you use so that more people can find the podcast. Have a blessed week, everyone, and tune in next Monday for another candid conversation on Living with FASD.